Welcome to all of you. I'm Darshak Sanghavi. I'm the Richard Merkin Fellow and Managing Director of the Engelbrecht Center of Healthcare Reform here at Brookings. And on behalf of our whole team, we're really excited to see you all here today. So I want to welcome you to our the second talk in our series on the Merkin series in innovation in healthcare delivery and payment. And in many ways, this initiative plays a really important role not only for our policy work here, but more broadly across the nation. Using an innovative narrative approach here, we try and make healthcare reform, healthcare delivery, and healthcare payment more accessible to clinicians, policymakers, and ultimately patients, ideally in a way that then inspires them to go on and make change themselves. You'll see that narrative approach here today, starting with real patients and what they have gone through, and then moving on to clinicians, researchers, policymakers, insurers, and those really that are trying to make change on the ground. Ideally, they're all problem solvers working together to the common goal. In this case, to make patients' lives and experiences better when going through the experience of having cancer. So I think that you'll find this a really fascinating and valuable discussion. And we'd like to also make it interactive. To that end, we'll be tweeting live with the hashtag MEDTalk. And if any of you have any questions or points of discussion, please tweet your questions to that, and we will be answering them at the end of our program, when we'll have a Q&A session with all of our speakers. I'd like to extend a thank you to our staff here at Brookings that's made this possible. In addition to that, also to Mark McClellan and Alice Rivlin, who direct our center here and work with us very closely. Although they couldn't be here today, they've been closely involved in planning and are aware of our work here. Finally, the Merkin Family Foundation has been very generous in supporting a lot of our work here at Brookings in innovations in payment and delivery reform. And finally, to the Healthcare Innovation and Value Initiative here at Brookings as well. So without further ado, I'd like to go ahead and get started, and I will pass along the mic to our opening speaker.
Hi, my name is Andreen Taylor, and very excited to be here. So thank you for this opportunity. And I'm very excited to be a part of this conversation. I am a 3-time cancer survivor. I was diagnosed when I was 25 years old. I was a graduate school, so that was not the news that I was looking for. And before I get into the diagnosis and the story, I want to just give you a little bit of background about how it all happened. So it was the summer of my 25th year, and I'd felt a little lump on my neck, and I ignored it. It was the summertime. I thought I was transitioning into maybe a summer cold, and I was like, oh, I'll just, it'll go away. And it did go away, the pain. And then it came back, and it persisted. So I had a boyfriend at the time, and I was like, oh, can you just massage this away? And he was very diligent about putting icy hot on it at night and trying to make the pain go away, but it wouldn't go away. And eventually I just couldn't sleep at night because I couldn't rest on my neck, and it was very disturbing. So I finally decided to go to the doctor. I was a student, so my point of entry into care was through the Student Health Center. And luckily, I had a great doctor at the Student Healthcare Center. I went to Howard University here locally, and we talked, and we didn't, it could be anything. She just told me, just go ahead and find out what's going on. And I was like, okay, all right, yeah, I got this. I can do anything. Before my appointment, a few days before, I started doing my due diligence of self-diagnosis. So I got on the internet and I started, investigating, and, it could have been anything. It could have been some like toothache that went wrong. It could still be swollen glands. But, intuitively, as I began to do the research and read all these different articles, there was a stirring inside of me that let me know that, you just don't have lumps growing on your body. And so I went to the doctor, and, after a few tests, a few weeks, he did tell me that it was cancer. And I was like, well, do I have to tell my parents about this? And he was like, yes, this is something that you have to share with your parents. Cancer, and he told me it was Hodgkin's lymphoma, which, according to him at the time, was a good cancer. 90% of people who have cancer, they get treated, they're A-okay, they're done. But I fell into that 10 percentile, and it didn't really work out that way for me. I had 3 reoccurrences that took me on a cross-country journey of integrated health. I was treated twice at Howard University, chemotherapy and radiation. I had a fellowship during this whole experience, and I told my doctors, like, no more treatments. I'm going to California. I'm going to cure myself. I went out to California. I, was at City of Hope, which is a very great hospital. And, I did prayer and meditation. Cancer went into remission. And then came back after the fellowship was over, and the cancer came back again. And so this time I decided that I wanted to try something a little different. So I persuaded some wonderful doctors at NIH to include me in a clinical trial. And I was a part of that protocol for many years. And unfortunately, that trial did not work for me. But I'm glad that I did it because, women like me, women of African descent, we don't typically participate in trials, and that was very important for me to, have that experience. And NIH is another wonderful hospital. So that didn't work. So the doctors, they were like, we really have to do something differently. And so about 2 years ago, I had a stem cell transplant at the University of Maryland. And that was by far the most challenging cancer treatment I had ever had. I don't know, I'm sure some of you might know a little bit about stem cell transplants, but basically everything inside of you is wiped out. And you're re-injected in with your own stem cells, and the idea is that, your body can heal itself and regrow. And that was supposed to be a cure. Luckily, last time I checked, and I'm going to get into that whole checking, I was fine. And through this process of having cancer and being treated, I learned a lot of things. One, I learned who I had to show up as a patient, and what that meant to showing up as a patient and how I wanted to be treated. And unfortunately, I've had more challenging experiences than I've had really, not so challenging experiences. And among the challenging experiences that I've had was dealing with doctors who treated me, 1, because I'm young, that's probably part of it. 2, I'm a woman. And 3, I'm a black woman, and that has something to do with it as well. In a way that I felt was unfair. I definitely was a person who wanted to be a part of my treatment. I wanted to know what was going on. I wanted to know why we were choosing this course of treatment versus that course of treatment. I had questions, and my questions deserved to be answered. And through the process, that was challenging for some doctors. And in fact, during my first course of treatment, I had a doctor that, didn't like my participation in care. And, I wanted to see my scans, I wanted to know, I wanted to talk, and, he just wasn't that responsive. And I went to the hospital one day, and, I'm a graduate student. All I really want to do is finish my thesis, move on to my PhD program, maybe pick up a publication on the way. I didn't want to have to deal with, this man, who was treating me less than. And I went to the hospital one day, and I had a wonderful nurse. And I was talking to the nurse, and I was like, I just don't know what's going on, and I don't know, is it working, is it not working? It had been months, it had been almost a year in, and, and I just told her, I said, you know what, I don't want to be treated by him anymore. And she said, are you sure? And I said, yes. I said, I would rather die than let this man prescribe another course of treatment for me. I don't know what's going on. And it was frightening because it was like a relationship, you know, that I had with this doctor, no matter how challenging it was. In a way, he had my life in his hand as far as I knew. And so that was heartbreaking. That was like my first real breakup. And so we ended that relationship. And what I realized that, you know, through this treatment, there are, you know, lots of women that are having my experiences in treatment and dealing with doctors. And our stories are not being told. And I wanted to do something a little different. I wanted to create a forum, a platform where, you know, we can know about stories that are like mine. You know, Tisha talked about the narrative of cancer. And my story is not often included in that. And I started this project called the Exposures Project. And basically what it is, it's from my organization, Zori Works for Women's Health. And it is a health and arts communication. And we use arts as a way to advocate for healthcare reform and you know, improvement of quality of life of women who have cancer. And so with this project, what we do, we, you know, talk to women who are currently in treatment or just recovering from treatment. We teach them how to take photographs, how to document their stories, and we train them to be health advocates in their community. And the idea is that from peer-to-peer communication that we can create change. We can create change by telling another person how I went through this, how I dealt with that challenging situation with my doctor. You know, how I managed to create a coordination of care between doctors and, you know, pharmacists, and how I, you know, am able to survive, because rarely do you see images of women who look like me saying, I survived cancer. So this project likes to, you know, highlight those stories. And one of the women that we helped is Debbie. She's 29 years old, stage 4 breast cancer. It metastasized. She ended up having bone cancer. And Debbie is a very special case because she is an African immigrant and she raised money to come to the United States to get treated. And through the process of her treatment, she lost her housing, and we had to help her find a home. And these are issues that no cancer patient, no patient should have to deal with. It's horrible to come home from chemotherapy not knowing if you have a place to live and having to sleep on the floor. So we help make a difference in her life in providing those services for her. And I guess one of the major things that I think as we have this conversation and we think about, you know, how can we create a system that is more focused on the patient and, you know, focusing on healing the patient. It's developing systems, one, where patients are a part of the process, and that there's a coordination of care among doctors and all of the other support staff. You know, a lot of people say, like, the government, oh, I don't want them on in my healthcare. But I'm going to tell you, my experiences at NIH was among the best experiences I have ever had in a medical facility. They spoiled me, in fact. The coordination of care at NIH Hospital was magnificent. So that's a very important issue that I think that we need to address as we move forward in this conversation about how we focus on helping our patients and making a difference in healthcare and healthcare delivery. So thank you.
So good morning, everyone. My name is Rich Shilsky. I'm a medical oncologist. I'm the Chief Medical Officer at the American Society of Clinical Oncology. Prior to joining ASCO about 18 months ago, I was on the faculty at the University of Chicago for nearly 30 years in a variety of different roles there. I want to take you back to the battlefields of Europe during the First and Second World Wars, when mustard gas was used by the combatants on the battlefield. Mustard gas is a highly volatile, toxic, yellow cloud. If you inhale it, it will burn your lungs out. You will die from acute pulmonary hemorrhage. If it touches your skin, it'll melt the skin off your arm. And it can cause instant blindness by destroying the corneas of your eyes. It is not a good death. But if you survive mustard gas, and some of the soldiers did, it was then discovered sometime later, months later, that many of these soldiers now had a new medical problem, they had anemia. They had low white blood cell counts. They had hemorrhage because they had no platelets in their blood. And when they were evaluated by their physicians, it was discovered that they now had a new problem of bone marrow aplasia. The bone marrow had been wiped out by the exposure to mustard gas. So this actually led people to think about whether derivatives of mustard gas might actually be used in the treatment of rapidly growing blood cancers like leukemia and lymphoma. And it led in 1947 to two pharmacologists at Yale University, Louis Goodman and Alfred Gilman, getting a contract from the federal government to study a derivative of mustard gas called nitrogen mustard. Nitrogen mustard is a kind of a drug called an alkylating agent. It was the first alkylating agent that was brought into clinical development. And Goodman and Gilman gave nitrogen mustard to mice with leukemia, and in fact they found that it eradicated the leukemia and the mice were cured. And then they tested nitrogen mustard in normal mice and normal dogs and discovered what its side effect profile was and what dose might possibly be administered safely to a person. And they prevailed on a colleague of theirs at Yale who was treating a young man with an advanced lymphoma who had no other treatment options. They prevailed on their colleague to give this patient a trial of an infusion of nitrogen mustard. Remarkably, the patient's swollen lymph nodes disappeared, the patient's abnormal blood counts returned to normal, and the patient entered a remission. It was the first demonstration that chemotherapy, treatment with drugs, could actually be effective in treating a patient with advanced cancer. Unfortunately, that patient's remission was not long-lived, and the cancer ultimately came back and the patient died. But that observation opened up the field of chemotherapy treatment for cancer, along with work that was going on around the same time, excuse me, again in the 1950s by Sidney Farber at Boston Children's Hospital. Farber was a hematologist and a hematopathologist, and he had made the observation, looking at the bone marrows of children with acute lymphoblastic leukemia, that the bone marrows resembled a condition that he had seen in adults, a condition related to deficiency in the vitamin folic acid, known medically as megaloblastic anemia. So he thought, well, maybe leukemia in children is due to folic acid deficiency. And he treated children with large doses of folic acid. And their leukemias grew like wildfire. The leukemias just took off, and the children rapidly perished. But it led him to think about whether or not, if the cancers are stimulated to grow by folic acid, maybe they could be inhibited in their growth by using an antagonist of folic acid, an antifolate. That led to the development of another new class of cancer chemotherapy drugs, the antifolates, the first of which was amethopterin, the second of which was aminopterin or methotrexate. Methotrexate is still in use today, and one of the mainstays of treatment of childhood acute leukemia.
And we have our pathway project for triage pathways, where I wrote out, and we've computerized how we manage these side effects and what we draw and what needs to happen and when the appropriate lab tests and x-rays are, so that we can deliver that care very efficiently. We have a team-based system where every member of the office has to switch the idea from, if this is a medical emergency, hang up and dial 911, to how can I help you get what you need right now? So if somebody doesn't have that attitude of how do I help this patient in front of me get what they need, they don't have to work for me. There are other jobs out there. If they want to work for me, they have to have that attitude. So we bring people in and we get them what they need. The other thing that we're doing is the the diagnostic and therapeutic pathways, so that we can put the genomics in the right place, put the imaging in the right place. And I don't do this, frankly, to save the insurance companies money, but I know you're shocked. But it's the patients who are paying those copays who recognize that if we a scan, making somebody go through a scan is not only expensive, it's uncomfortable. We don't want to do that any more than we have to. And we need to use those tools, but we want to keep that cost low. So as we look at this and as we gather the data, part of what we're doing is delivering the data back to the doctors so that they can use that data for self-improvement and be able to follow these pathways so that we can actually get real clinical outcomes, looking at efficacy and toxicity and eventually cost. So the other thing that we're learning very quickly is what are the costs of delivering this kind of care? So healthcare is mostly people taking care of people, and people need to be paid salaries. So if we're going to hire people to, for example, stay until 8 o'clock at night, which we can now do courtesy of the CMMI grant, and have people open on the weekends and the after hours time so that we can get those same day visits in, what we find is that we are having increasing expense because you have to pay the staff to be there. If we, for example, see 10 patients in the after hours clinic, that is not enough patients to generate enough E&M codes to be able to pay the salaries of the people who are working there. On the other hand, if those 10 patients go to the emergency department and spend a whole lot of money, and 60% of them who show up in the ER are going to get admitted, which is even more money for unnecessary things, that saves the system a lot of money if we can avoid that. But we don't get that money. So what we're learning is that this is actually not going to be a sustainable model unless we get rid of the fee-for-service system and come up with a bundled payment and share in some of the savings that we're creating from keeping people out of the hospital. So to talk about that part of it, I'll introduce Laura.
Thank you, Barbara. Good morning, everybody. My name is Laura Stevens, and I'm the Program Director and CIO for the Come Home program, which is our CMMI funded grant. And Come Home stands for Community Oncology Medical Home. I'm going to let Rio do my clicking for me. There we go. I think in every part of our country is so different. We've got, you know, the lakes and the cities and everything. But one area that we share is across the country is our healthcare problems. We all share in that. And what we need to do is come up with sustainable and scalable ideas. So that is what really is the whole idea of our program, our Come Home program. In 2012, we received our CMMI grant to implement the Come Home program. We have 7 different practices. If we could just go back one more, thanks. 7 different participating oncology practices. They're in Florida, 2 of ours, in Austin and Fort Worth, or in Texas, our New Mexico Cancer Center, Dayton. We have a large practice in Northwest Georgia. And then way up in Maine, we have our Maine Cancer Center, very innovative. So what we try to do, and people have asked us all the time, how on earth did you select your 7 participating practices? So if we go to our next slide, thanks. This is our Come Home model, and this is really what we used as the core to select our practices. First of all, they had to be fully implemented on an EMR system. We talked about earlier, a number of our speakers have said that data is critical. The physicians absolutely in the practices had to be able to capture, had to be able to maintain, and more so, share data. We did team-based care. The physician leadership is absolutely key in selecting our practices. The belief in the program had to be from the top down to the bottom and bottom up. And team-based care, as you heard Barbara mention, we expect everybody within the practice to be accountable for the patient's care. From the people that answer the phone, we call them first responders, to the nurses, physicians, everybody in the office has some accountability to that patient. The other areas that, and I'll talk about in a little bit, is expanded and enhanced access. And then also the ability, I want to say that we also looked for practices that had in-house imaging, lab, pharmacy. If they didn't have it in-house, then we looked for them to have favorable contracts with facilities that were very nearby, obviously, so when the patient is there in the office and if they need the care, they can get that care that day right when they're in the office and receiving their office visit. The other thing that I think what we really focused on, people had said, what is the right size? And that was probably our biggest challenge. If a practice, an oncology practice, was too large, they probably already had market security. If they were too small, and some of them that were very interested in the program unfortunately really were too small, they just didn't have the infrastructure to implement and support the Come Home program. So we looked for a practice that was the right size. And the right size is probably somebody that was worried about maybe becoming extinct in the next few years, but had the willingness and the desire to implement the program. So if we go to the next slide, there's some very key components of the Come Home program. And people say, so what makes this program really different? How do you tell people that what you have is so different? And really what we have are these key components, and they work together, and working together, this is what makes our program successful. We talked about the team-based care. One of the biggest components is the triage system. These are symptom management pathways. There's 32 of them right now. We're adding more. It's automated. They're for the triage nurses. It's a real-time decision-based system that the triage nurses use. Our hypothesis is that if we can do aggressive symptom management for patients, that will directly reduce the ER visits and costs and inpatient hospitalization. So our triage system is absolutely key. The other piece to that is our enhanced access. And in part of that, I always talk about same-day appointments. If a patient calls in and they're assessed by the triage nurse, the nurse they work to the top of their license. They say, you know what, I think you really should come in. I think you really need to be seen by the doctor today, so come on in. So that's key. Enhanced access, you may have already mentioned, Barb mentioned, is extended hours during the day. Most of our practices are open to 8 in the evening, and they're also open on weekends. Our practices are open at least 3 or 4 hours on a Saturday and a Sunday, again, for our patients to receive the care that we want, and we want them to get. And then I think what Darshak had asked me too, he had asked, can you give us a story or an example of how a patient really is impacted by the Come Home program? And I think the best one is a daughter that's caring for her mom that has cancer, comes home, walks in, looks at her and says, oh my gracious, Mom, you look terrible. I'm calling your doctor. Picks up the phone, she calls the doctor. The office is closed. You get the message, if this is an emergency, please call 911. Daughter looks at her mom and says, oh my gracious, Mom, get in the car, I'm bringing you to the ER. And then just as Barbara said, the story goes where the patient is, the mom is in the ER for probably a number of hours before she's seen. By that time, she really, really is sick. The doctor doesn't know her care. Probably runs a number of tests that probably may not necessarily be needed. And then, as Barbara said too, I believe the stats are 60% of patients that go to the ER that have cancer are going to be hospitalized. So flip to our Come Home program. The daughter gets home after 6 o'clock, looks at her mom, she's really sick. Mom, I'm calling your doctor. Somebody answers the phone, asks her a few symptom management questions. They say, just come on in, let's see your mom this evening. I think what the process is that the good thing is the daughter brings the mom in, sees care, gets maybe hydrated, goes home in 2 hours. It's so much better for the patient. Go ahead, Rio, thanks. So our goals, so let's talk about the program. We really are seeing that it's working. Our emergency room costs and utilization are down. Definitely our inpatient hospitalization, drugs. These are proven cost savings. However, one of the things that we want to do is assess, so we're saving money, and the question that comes up, well, that's good, you're saving money, but what about quality? So we do definitely a lot of quality maintenance and reporting. Patient satisfaction, our scores have just continued to climb. Patients love the program. Provider satisfaction, that's really important. At first, when we first started, there were a couple doctors that said weekend hours, so it's important to make sure we track the provider satisfaction. Compliance, Dr. McEnany talked about our pathways. We had pathway development teams from each of the practices. Physicians were on each of those calls. They developed their own evidence-based pathways, and we do the monitoring from that. We collect data from the EMRs. So our challenge is, we know our idea is working, and our challenge is, so how do we keep this program going? And what we're going to be doing, and Darshak is going to talk to this, is we're going to be working, looking to work with payers to come up with a bundle payment to help with the shared cost savings so that we continue on with our program. And with Darshak is going to help us with some of the ideas as far as payers go.
Thank you very much. So I'm Darshak Sanghavi from the Brookings Institution, and I'm going to pick up on some of the threads we've heard throughout a variety of the talks today and try to lay out a framework, at least the way I think we should all think about how we're trying to make positive change in healthcare today. So one of the things I'm always struck by is in the 1970s, if you were a child with leukemia, you had about a 90% chance of passing away. Very, very caring physicians, parents, even the patients themselves and the system work together so that approximately 25 to 30 years later, instead of 90% of those children dying, 90% of them were actually living. And why is that? Was it an amazing new chemotherapeutic agent? Was it new technology? The answer is none of the above. In fact, over that period of time, not a single new pharmaceutical agent was developed. Instead, it was taking and refining what was already known, managing side effects, and that's what led to that improvement. And I tell that story because in healthcare today, I think we have two general kinds of problems. The first are gaps in knowledge. So as you heard about, we have extremely sophisticated researchers that are doing cutting-edge work trying to figure out new cures, creating new pills that will cure cancer possibly someday. But on the other hand, we have issues of coordination, of simply applying what we already know. In other words, why aren't we doing better with what we already know? And that's really the opportunity we have when we talk about healthcare delivery reform and how do we then support that with payment reform. It's that type of problem. And there's a lot to that. And those can fall into many categories. I'll just mention two. The first is, as we mentioned, drug costs. We have seen that this is in adjusted 2012 dollars, that drug costs per month for the average patient with cancer have risen from $4,500 a month to $10,000 per month. A massive increase in the amount of money that insurers and ultimately patients may also have to bear because there are co-pays. And I've included a graphic there because in today's day and age, in one of the most highly industrialized countries today, 25% of people who have cancer will actually burn through all of their savings in order to help pay their responsibility for their care, even when they actually have insurance. Just think about that. So those people are really wiped out, not only by the biological reality of their disease, but by the economic reality as well. That's a little bit of the economic toll. The second is the quality issues. There are many, many extremely caring physicians out there, many, many extremely caring nurses and systems, and yet even so, 22%, that's 1 in 5 patients who have colon cancer, do not actually get the recommended care even when they interact with the healthcare system. For breast cancer, that's 15%. Think about that. Almost 1 or 2 in 10 women who have breast cancer also do not actually get recommended therapy. And remember, this is on top of some of the issues you've already heard from Brian and Bill, that many patients are actually misdiagnosed as well. So these are some of the challenges we're talking about dealing with when we talk about healthcare delivery reform and payment reform. This is stuff we already know. We don't need to go back to the lab and invest billions of dollars at NIH to figure this stuff out. We just need to do better with what we already know. So this is a broader issue. How do you get people to change? How exactly do you change systems to make them better? I'm going to start with an example. I'm a parent. I have 2 kids. I've had them in daycare. And some of you may know daycare is a microcosm of all of your entire life. And I'll say that because in the 1970s, actually, some of you may remember, Paul Krugman, the economist, looked at a daycare center in Washington, D.C., where they had a voucher system, and in that saw sort of the issues that arose with non-liquidity, and thinks about that with recessions and how to stimulate the economy. And that's been formative in his thinking about how he thinks about economics today. Similarly, in daycare settings, I want to call your attention to a study that took place in Haifa, Israel, some time ago. Parents... The daycare center had a problem. You know, when your kids are in daycare, you got to pick them up at a certain time. And as many professionals know, you're always rushing out of the house in the morning. You know, I'm a physician. I'm guilty of when my kids had a little bit of a fever, bolusing with ibuprofen as they go out the door, knowing that 6 to 8 hours later I get a call that the child had a fever, and I plan my day around that. On the other hand, at the back end, you know, 5 o'clock rolls around, you can't be late. And this is the problem they had in Haifa. Parents were running late because they wanted to pick up their kids. And so they said, well, how can we use economics? How should we essentially use payment reform to change delivery reform? We want to make this better. And so they said, look, we'll use an economic incentive. If you're late picking up your child, you'll pay a penalty. And what do you think the result of that was? Twice the number of people started being late to pick up their kids. This is exactly the wrong outcome of what you wanted, because the way the incentives were designed failed entirely to cleave to the objective. Now, this is actually something which has been talked about by Daniel Pink in his work on motivation and drive. And this is a little cartoon taken from one of his talks. How is it that if you actually reward or create incentives that the system gets worse? Isn't that exactly the opposite of what economics incentive teaches us? And Daniel Pink draws our attention to one thing which I think is profoundly instructive when we talk about healthcare payment and delivery reform. And it goes like this. They took a bunch of students who were trying to learn math, and they gave them economic incentives. If you actually study and get a certain grade, you'll get paid a certain amount, right? So you get an economic bonus. And this was actually repeated in many, many other settings around the world. And if you actually did really, really well, you got a huge bonus. You got a lot of money. And they sort of repeated this study even in India, looking at workers as well. And what did they find? If you actually added an economic incentive to those individuals to see if they could learn a new skill, right? This is what we all do. We bribe your kids. You bribe doctors. You try to get them to do the right thing. What happened? In fact, money had exactly the opposite impact. It had a tremendously corrosive influence on physicians, learners' ability to actually improve behavior. And what grew out of that is this seminal observation, which I think should guide us when we talk about payment and delivery reform. It is that when you are doing things that are simple, making widgets, when you're kind of making sure you show up on time, manufacturing basic things, repetitive tasks, those kinds of economic incentives work very well. On the other hand, when you have complex tasks, trying to change your oncology system to take care of complicated problems, economic incentives actually have an opposite impact entirely. That is one reason why, in Pink's estimation, and again, what the data strongly shows is that there should be a three-pronged approach to improving and enhancing behavior when we think about how do we incentivize this. And I think that Pink actually has this quote, which I'll read, which is, you pay people just enough to take money off the table. And you let the rest of their natural impulse to do the right thing shine through. And I think this is sometimes seen as hopelessly naive. But I can tell you, when you look at the work of people like Barbara at New Mexico Cancer Center and many other physicians with whom we work, nurses, nurse practitioners, physical therapists, pharmacists, and others, they truly care a great deal about doing the best they can. And so there's this three-pronged approach, which is you want to focus on these things: autonomy, mastery, and purpose. Those are the things that actually internally drive people to continue to succeed. And in fact, these fall right into what we think of as clinical drivers. Autonomy, what is that? That's clinical judgment. You want to give providers the ability to do what they're trained to do without creating way too many rules, the mother may I approach, which is why it failed, which is why pay for performance is really roundly condemned by many, many providers, and they don't want to participate in value-based purchasing when it's on an individual physician level. Mastery, the other word for that in the clinical world is continuous improvement. It's what we all want to do. You get data, you get better and better, and that also is a virtuous cycle. And finally, purpose. Again, in our parlance, patient care. We feel driven by the morality, by the actual good work of taking care of patients. I think that's what shines through when you start being aware of that patient experience. What does this actually mean for payment reform? And I don't have all the answers. As you've seen, it's intensely frustrating. New Mexico Cancer Center, among many others, as an example, is doing the right thing in meeting and truly being patient-centered. And yet, despite all of the benefits that they have shown for patient care, are having a devil of a time finding an appropriate model to support them long-term to make this kind of work fulfilling and sustainable. But perhaps we can point to something that was in the news yesterday. I just want to point out how this can be helpful, which was, as was referred to earlier, we just got some preliminary data from United Healthcare's pilot programs. And what they did, to some extent, cleaves to Pink's formulation. What they did was they just paid for medications at cost. In the past, oncologists made almost all of their money as margin on giving pharmaceuticals. As you heard, that was really the buy and bill mentality. And instead with United, they just paid for the drugs at cost. I can't emphasize this enough. In other words, they completely flipped the model of how oncologists make money on its head. You didn't just get paid for giving more drugs and expensive drugs. And instead, they gave them essentially a bundled payment that covered their hospitalization costs, their emergency room costs, supported in a lump sum right up front exactly the kind of work that Barbara is talking about and Laura are talking about, which is making sure you're patient-centered, taking those phone calls. And what did they find? 33% reduction in total healthcare costs. Almost all, and this is still in evolution, through reduced utilization of inpatient hospitalization services and emergency room care. Well, at the same time, the drug costs actually almost doubled. So in other words, you gave autonomy to the system. You let providers do the right thing. You let them use their clinical judgment. And you also created a virtuous cycle where you allowed them to do what was best for their practices. So I'd like to at least close with this as a general framework, as a way to think about how we can move forward. And I think what I'd like to do now, again, just want to emphasize in closing that we will have time for questions. Please tweet your questions to #MEDTalk. I also want to let you know that we will be taking a lot of the work that's led up to the MEDTalk and releasing a very detailed white paper, which will be free to download. It has a huge amount of educational information for all of you who may be interested in oncology care, and we'll notify you about that. But I'd like to hand over the mic to my colleague, Dr. Kavita Patel, who will lead a question and answer session for a few minutes before the close of our program.
I think we're doing shares,
yeah.
Right?
We're just going to bring up some chairs.
All right, we're doing a little, I don't have fancy PowerPoint, so that makes me either very smart or very stupid, one of the two. So we're going to ask all our speakers to come up here. Are there people in the audience that have questions? If they do, raise their hand so we can get a mic to you. I see several in the back, so we'll get a mic to you. First, why don't we do a round of applause for all our speakers this morning? Oh, you have to bring your own chair. What a strappy organ is that? You got to pay to play. Okay, I can step off the stage or hide behind this tripod so we can get. You want me to get? Here
you go, ma'am. Here's one of our mics.
Do like a choir seating and do. I'm here. I'll just stand here because nobody. I'm not the important person. All right, why don't we? We've got mics here. Who's got mics in the back? I'm trusting back there. All right, go ahead and stand up and just briefly, since I'm doing a little bit of timekeeper. Go ahead and stand up if you have a question. Stand up and briefly introduce my job is the bad cop. Brief and potentially who you want to address it to, since everybody can't speak.
My name is Chandra. I'm a physician. I also
And I can't hear. I'm sorry. Yeah, he's got a mic. I just don't know. All right, if there's another person with a mic, go ahead and go. And then that way we can, while we're waiting for, I don't want to waste any time. You've got a question, sir? I can probably hear you, and then I can repeat it for the webcast.
Yes, my name is Bob Rosenblatt. I run a website called helpwithaging.com about Medicare issues. I've talked to a number of doctors with oncology practices who say they're telling their patients, get the infusion in my office, even if there's a pill, because you will pay less in my office under Part B. If you get a pill, you're going to have a huge exposure under Part D, same treatment. I'm wondering if this is good advice, because it seems to be a huge price difference.
All right, so let me repeat the question and skew it a little bit, because I'm not sure I want the panel to give advice about Part B versus Part D, but more, I think, to a question around cost and having physicians play a very common role in asking whether or not it's helpful to direct patients who might face higher out-of-pocket cost because of the differences in how we finance oral versus intravenous medication. So, Barbara, everybody's wanting to hand that mic to you. Can you give us a brief answer on how you would address that?
And I actually get that questions from patients. Can't you please give me this IV because I can't make the copay? And it is a very strange system. The problem is the drugs are not the same drugs generally. There's only about 4 drugs that you can give IV or PO. And the rest are, PO is by mouth, and the rest have to be given the way that they're given. It is a problem to have the orals in the pharmaceutical benefit of both the private plans and of Medicare, frankly, in the Part Ds, because then there's not just a deductible, there's co-insurance, where of that $10,000 a month, the patient gets to pay 20% of it. And my own preference would be to have that all be in the medical benefit so that we can manage it and we don't have to deal with the copays and what do you do with the drugs if they can't tolerate the oral, you flush $10,000 worth of medicine. That breaks my heart. So I think one of the basic problems is that the co-insurance system for orals is set up to try to direct people to lower cost alternatives like generic drugs, but there aren't generic drugs for these. So all it does is shift the money from the payer back to the patient. And again, if we had a bundled payment system where we could manage all of these things and the drugs were in that bundle, we wouldn't be stuck with trying to direct patients one way or another. We could just give them the drug that worked best for them and not worry about the payment level so much.
Great. Now go back to the gentleman who had the mic in the back. Hopefully it's working. And stand up and tell us who you are and your question briefly.
My name is Chandra. I'm a non-practicing physician. The question is for third speaker, the future of oncology, that is Richard. You said you are talking about cure for cure. When do you call the cancer is cured? If the 70% of patients live for 5 years without primary and secondary, you call it as a cure. Or sometimes patient may develop a second cancer because of radiation and chemotherapy, since the radiation chemotherapy bring down the immunity. In that case, how do you call it a cancer? Because this may, how do you call it as a cure? Because this may be connected to the bundling of payment. If the patient develops a second tumor following the following the chemotherapy for the primary tumor, how are you going to account for that as a cure? You understand the question?
I do understand the question. To some extent, I think it's a matter of semantics in the sense that if the patient's treated successfully for their cancer never comes back in the remainder of their lifespan, they're cured. You never exactly know that while the patient's alive, because there are examples where cancers can and do recur 10 and 20 years after the initial treatment's completed. With respect to secondary cancers, that is, cancers that develop as a consequence of the initial treatment, that is a very serious and unfortunate medical complication of treatment for the first cancer. Of course, it's sort of a prerequisite to cure the first cancer in order for the patient to survive long enough to get the second cancer. And it doesn't negate the impact of the initial treatment, but it just tells us that we need better therapeutic strategies so that we can continue to cure patients and not induce additional cancers further down the line.
Bill, you wanted to add to that? Pass the mic.
One thing in this space is I think as we have begun to keep better data and more comprehensive data of someone's experience with healthcare over time, is if you look at the non-cancer care costs of a long-term cancer survivor, stuff that doesn't relate it to whether that they got another, it's easily twice that of everyone else. And so that's something that I think we can also think a lot about, how we manage those people and manage them more effective with greater quality and ameliorating other health challenges and risks that they have. So,
great. Do we have another question? I think that was gentleman with the mic.
Yeah, hi. Hello, my name is Kasha Frisbee. I'm a medical oncologist out here in Silver Spring, part of U.S. Oncology. And my question is twofold. There's no question that there's an opportunity to improve the quality and reduce the waste in the current practice of medicine and oncology specifically. And all of these efforts are tremendous and will clearly do a lot for our patients. But one of the areas that I feel has not been addressed and doesn't seem to be addressed on a regular basis is the cost of drugs and the fact that much of the R&D that private pharmaceutical companies derive their proceeds from are on the backs of the U.S. market, and that the rest of the world does not have to share in that same burden. If we're recognizing the fact that Europe pays half the price per patient than the United States, is that not only a reflection of some of the inefficiencies we have, but also in the cost of drugs?
Well, that's a very straightforward question. I'm sure everybody wants to answer. So let's, Rich, go ahead.
Well, let me start. So, you know, what many other countries in the world have that we do not have in the U.S. Are two activities that go on every time a new drug is ready to be introduced into the marketplace. One is an activity either by a governmental agency or a non-governmental agency that evaluates the relative value of that new treatment compared to prevailing standards of care. And the second activity is usually the government health service negotiating on the cost of that drug in that healthcare system. We don't do either one of those things in this country, you know, where we have a completely free market economy, where drugs come into the market priced usually in relationship to what the last drug in the market was priced at in that particular indication, where we do very little to evaluate the relative incremental benefit of new treatments when they're introduced. And I would just say quickly, you know, this is a major initiative that ASCO is taking on right now through a task force we have called the Value in Cancer Care Task Force, which has been looking for the last more than a year now at how to evaluate the relative value of new treatments introduced into the market. We expect this fall to be sort of unveiling a methodology for making those evaluations that hopefully doctors can use in discussions with patients about how to assess the relative value of new treatments compared to prevailing standards of care.
Brian, do you want to add something to that just from a payer perspective?
Now, another thing from a payer standpoint that's really, that's frightening about this is not only the cost of these new drugs and the profit that they're taking out of, but the new biologics. We don't really have a good biosimilar strategy. We don't have a good transition to generics. So a new non-biologic drug comes in and it has a patent period. So the company makes their profit for a period of time, and then over time, established therapies, the cost goes down when they become generic. That pathway doesn't seem to exist yet for biologics. And these are very, very expensive drugs that are proliferating. And you can make a case that yes, pharmaceutical companies, they need to get back their R&D, and they'll get it back in early years. And then, once they've made their profit, they'll move on to other development. But at this point, you have a major biologic that gets market share. It's an annuity. And I think that's a real problem that we have to address just in the total cost of care.
And Bill, final thoughts on this question.
I was going to ask a question. Actually, full disclosure, I'm a fan of the R&D in the pharmaceutical industry. I'm glad we're creating new anti-cancer drugs. One of the things I would rather they not do personally is direct-to-consumer advertising. And I wonder how much that complicates attempts to establish better quality care from the perspective of a payer or somebody trying to organize care. I don't understand any value in direct-to-consumer advertising for healthcare. I understand the value to them, but just But without saying something controversial, I'll let you say it.
Barbara always gets to do that. I don't know if either you or Andreen want to speak to that, kind of the consumer, how messaging to consumers and how this matters when you, I mean, my experience as a doctor, you know this too, Bill, all of us who practice and see patients, they really heavily depend on what their doctor tells them at the end of the day. And sometimes, that's informed by the best of evidence. And as Darshak said, sometimes it's not, because we know there's a variation in quality. But how is kind of the appeal to consumers directly having an impact from?
Well, personally, I don't like it. I think it's a dangerous practice, and I think it has potential to sway patients away from directly engaging their doctors in a meaningful way. So that's my opinion about it. What about you, Barbara?
Well, I also don't like the direct-to-consumer advertising because it creates false hopes and expectations. If we can cure everything kind of idea. One of the things that we've done through the Come Home project is really invested a lot of time and effort with nurses and others, everybody, doing patient education, starting from what is a cancer and how does it work and how do these drugs work. And what we find as we do that, as we can direct patients to the valuable websites and away from the sham-like websites and give them information that's vetted and accurate, is that they're hungry for this information. It becomes an ongoing learning process, and it also builds that physician-patient relationship that is so crucial to be trusted purveyor of information. It allows us to do things like say, you really don't need to spend $1 gazillion on a bunch of vitamins because your disease is not a vitamin deficiency disease, and we can explain why. And it also allows us to do things, just that patient partnership allows us to do things like really talk about what is the value to you and your family as an individual with this, X line cost of therapy for your cancer. Do you really want to do that or not? What are your goals and what are your end-of-life choices when it comes to that? And I think that relationship is a lot of what can lead to a lot of the savings, get rid of the direct-to-consumer problems, and be able to get patients to be able to say, this is what I want, and your job, my job, is to help them get it. And I think that's key.
And I'll say some of the new, the United article that's in the JOP talks about how they tried to deal with the drug piece, and yet again, it's still not. Pathways try to do it. Brian mentioned that, but while 60 to 80% of an oncology practice's revenue, on average, when you're looking at national data, comes from the margins on drugs, I can tell you doctors don't necessarily want to be in the middle of this either. So but it's hard to switch gears to a different revenue model kind of overnight without completely destroying the infrastructure of how you've set up a practice. So I think that's complicated.
I got a comment to that. Sorry. But you're right, that the revenue from commercial chemotherapy pays the bills that keep my office open. I lose money every time I treat a Medicare patient, sorry.
And Medicaid as well.
Medicaid is even less. But one of the things that happens, and one of the reasons that as an advocate for going past the fee-for-service system, is that there are a lot of services for which there are no fees. And there are a lot of services for which the fees do not cover the cost of providing them. So this whole focus on, is it bad or is it good to have a drug margin? I got to have a margin from somewhere, or I cannot pay nurses to educate patients. I cannot pay people to sit on the phone and call up patients and say, so how are you doing today? Are you doing better? Did you take your temperature? Oh, you did, and you have a fever. Why don't you come in here today? I can't do that unless we either have a bundled system or I cost shift from my commercial plans to cover my Medicares, to cover my Medicaids, to cover all the services we provide for which there is no money.
All right, I'm going to do, I actually want to ask both Laura and Patrick something. We do a lot of work at Brookings with oncologists. We've worked with ASCO on some of their payment reform proposal, COA, a number of the communities in oncology, and they had sent me some questions in advance because I don't know if they tweet. They're all seeing patients today, so they might not be able to get on the webcast. One of the biggest issues in trying to transition to everything that's been discussed today is data. Everybody's talked about it a little bit, And so Patrick and Laura, I'll get you two ready for this. One has always been the constant kind of comment that as a clinician, we know kind of what we do with a patient in that moment, in that clinical visit, but we have no idea when someone goes to an ER that's outside of, even in our system, I'm at Hopkins, it's hard to know if someone's in one of our emergency rooms at a point when I can do something about it, much less an understanding of what my own practice's total cost of care might be. So Patrick, I know you've been tackling those issues in some of the other models we've talked about. What are some kind of lessons you've learned in how to have that relationship between what Medicare can do and the claims data that you have access to, and how to get that into, you know, real clinicians' hands so that they can actually change or adjust and transform their practice? And then to follow on with that, Laura, to close it out, I wanted to ask you kind of what you've learned in the data exchange mechanism between what you're doing with Come Home and Medicare, and what would be some advice you'd give on how to, you know, scale that. What would you do if we decided to do this across the nation, and how to make it better?
Yeah, so a few thoughts and policy principles, if you will. One on the data is timeliness, which is always a work in progress, but as timely as possible. We've got on the ACOs, we're giving them monthly data feeds. That's great. So I think in future models, you know, that's our goal. Doesn't mean we always reach there, but that's the goal. Two, usable. So, and there we both, within CMS, and we enable an ecosystem to make the data usable. So there's a whole industry of vendors and others, as you know well, helping the data to be usable and actionable. And three, related to that, you know, you mentioned this example, which actually we've had a number of companies come forward and identify themselves to us that are actually doing very innovative things, everything from fingerprinting to other data, big data analytics, to actually do things like inform an ACO the moment a patient hits an ER or a hospital, which enables really interesting clinical interventions. So how do you enable an ecosystem and incentives that allow people to focus on those outcomes and develop those tools?
Great, thank you. Laura?
Sure, and I would think, I would just add to that, timeliness absolutely is key. I think it's really raising the awareness of how critical data is. It's that old, if you can't measure it, you can't report on it, or you can't report on it, you can't measure it. I think that, and Patrick mentioned this a second ago, as far as actionable, it does absolutely no good, one, to have old data, and I'm talking about if it's not real time, I talk about near real time, which is very doable. And I think it's just making awareness, and it's opening up the doors from physicians who haven't honestly really wanted to share data. It's wanting to it's sharing information with the payers, and the payers in turn sharing information back to the practices. The technology is there today, so that is not the blockade. It's the willingness, and it's the infrastructure. It's the awareness, I'll admit, on part of physicians to use their EMRs correctly. If there's data and there's structured data field, they need to fill out that information. If you put it in a notes, for the most part, you can't capture that information. So that's really what I would add, is it's really more of awareness, and it's how critical data is, and that data has to be shared.
Great, thank you. So we're out of time. I just got time warning, so I want to be respectful of others' time. If some speakers can hang around, folks that are in the room might be able to catch one of them on their way out, but we want to thank everyone. Join me in thanking our panel once again. Darshak, any final thoughts? Anything else to add? All right. I can scream it for you. All right. Thank you, everybody. Take care.